Hello, ladies and gentlemen. Welcome to the webinar, Dental Aerosols, a Significant Threat in Dentistry. My name is Dr. Martin Koch. Maybe you see that from the name Koch. That's a typical German name. So I'm from Germany. I'm here sitting in that wonderful building. It's not snow at the end. It's typical German raining weather outside. And today I will talk about, of course, SARS-CoV-2. I think this is of the most interest, why more than 1,000 people are registered this webinar. So today in Germany, 30,000 new incidences, and I think in the US, around 300,000 incidences. So therefore, I think it's well, a big issue to talk about aerosols and about dental aerosols. So let me introduce myself. First of all, here is my vita. I studied biology and biotechnology in Germany. And then I was a lecturer at the university in Aachen and in Cologne, and I'm focused on ergonomic dental hygiene and so on. And I'm now employed since more than 20 years at a dental company, Dürr Dental, which is not known maybe in the US. A daughter company is Air Technique. So I'm now the director of our academy, and my job is to teach people, to teach technicians, to teach dentists about ergonomic, about digital X-ray, and well, in these days, about the risk being infected by aerosols. And that's our topic of today. We will discuss the risks. We will discuss the risk between aerosols and dental aerosols. There is a difference. And we will also do a risk assessment, and we will ask the questions, are we playing Russian roulette? Are we the super spreaders? So hopefully I can give you an answer, and then we will talk about mitigation strategies. Well, we can fill another webinar just with mitigation strategies like mouth rinsing, etc., etc. So therefore I have to focus, and I will focus on the gold standard. That's what I think is the best mitigation strategy, and that's intraoral evacuation. So, and finally, I will give you some practical tips, and well, I will answer, well, that's my personal answer. I will answer the question, is there a significant risk in dentistry, a significant threat? So let's start and let's discuss and introduce a little bit the aerosol discussions. Well, I will not speak about the coronavirus. Well, I'm a microbiologist like Robert Koch. You saw that in the first slide. Robert Koch is not my grandfather, by the way. Koch is a very popular name in Germany, like Smith and Miller. But Robert Koch was a very famous scientist because he was the founder of microbiology. He, together with Louis Pasteur, he developed all that techniques to grow the bacteria. And he won, by the way, he won the first Nobel Prize in medicine. And to honor him, the official health institute in Germany, so that's your CDC, takes his name. It's the Robert Koch Institute. And here you will see some quotes from April this year. First of all, in April, everybody thought that smear infection is the main transmission route. But then the focus goes more and more to droplets and to aerosols. So therefore, even in February, by a study by Peng et al. From China, they came to the conclusion that people working in dentistry have the highest risk of contracting corona. And that's an issue we have to discuss. Let's look a little bit into detail. Let's go a little bit into detail about an aerosol. Well, by definition, that's just copied from Wikipedia. Aerosol is an aero solution. It's a suspension. It's a suspension of fine solid particle or liquid particles in air. And another interesting figure is that particles in the range of 0.5 to 10 microns can be inhalated and they reach the alveoli. And especially these dimensions are in focus to be important if you are then suffering on COVID-19. So therefore, these dimensions are really in focus, 0.5 to 10 microns. You have to keep that in mind when we talk about measurements to prevent, when we talk about mitigation strategies. So let's summarize just a quick overview over some studies. Well, I think it's quite clear that, and I think it's proven now, that the aerosol is the main route of transmission. Well, it's proven that it contains RNA from SARS-CoV-2. It's proven that they maintain infectivity, and we also know that they maintain infectivity for others. Well, and also the viral load is well known, more than 1,000 virants just by loud speaking, singing, etc., etc., etc. And another interesting statement is that there is a quite high probability that a 50 micron droplet contains at least one virus, and that is the probability 37%, which I think it's quite high. Okay, and let's now discuss the difference between aerosol or even a medical aerosol by intubation, for example, and a dental aerosol. Are we playing Russian roulette? I don't think so, because a dental aerosol is completely different. A dental aerosol is something you generate during this so-called AGPs, these aerosol generating procedures. Well, whenever you use high-speed instruments like turbines, red angle handpieces, green angle handpieces, you have to cool them. Otherwise, you would destroy your nerves. But water is also used as a transport media, for example, for this water jet handpieces, and they are quite popular in Europe. But also, water is used to rinse things, for example, in the 3-in-1 piston. So, and finally, we've got the ultrasound and surgical devices. Also, they have to be cooled by water. And whenever you use this kind of instruments, you generate aerosols. So to summarize, I would say you can't avoid that. Yeah, it would be a consequence to go back to hand instrumentation, but this is nothing we really want to reach. So therefore, my statement is you can't avoid that. Well, these dental aerosols, they contain dental water. Hopefully it's Legionella free, so then it would be another contamination risk, but it contains dental water, and only 0.4%, and that's a calculation from a study I read yesterday, 0.04% saliva and blood. So the main content is water, and that's the difference to the medical aerosol or the aerosol by breathing and speaking. Well, it contains microorganisms, bacteria, fungi, and I think it will also contain SARS-CoV-2. But maybe the viral load is too low to influence something. Well, by the way, they also contain these solid particles, two substance, plaque, amalgam, etc., and also these powders from the prophylactic units. So it's another difference. It's a complete mixture of solid particles, liquid, microorganism, pathogens in air. So this is a dental aerosol. Now, let's look a little bit into details. These are studies made in my lab, and we want to visualize these aerosols by a technique I will come later on. And I just start that video, and there you can see the aerosols that are generated by a turbine. It's a complete mixture. It's a full range of different sizes, starting, and that's what you see on the left side, starting on the right side with 200 microns, 100 microns in the center, and on the left side, particles that are smaller than 1 microns. So what you can see is that you generate a high amount of particles, liquid particles, because you cool these instruments with minimum 50 milliliter of water. And you generate a high amount of water, of aerosols, of particles, 0.2 to 200 microns. These particles are accelerated to several meters per second and emit the mouth. And to visualize that, I will show you a nice video, which is not published yet, from the King's College in London. And they test, or they visualize this aerosol particles by a new 3D method. It's with 4 cameras, and it's called laser something technique, and the different colors are the different speeds. Red means high speed, then yellow, and then blue. And what you see there is these particles, and they can only visualize the bigger particles. They showed a ballistic behavior. So they emit the mouth with a high speed, and then you have got the gravity, and the gravity slow down these particles. So, and then the ballistic behavior depends on the mass of the particles. The small particles, smaller than 5 microns, they will be airborne, and that's what we called aerosol. And then there are particles in the range of 5 to 50 microns. That I would call droplets. And particles that are larger than 50 microns, I would call them spatter or splatter. But this is just a theoretical fragmentation, because we know that from a 50 micron particle, for example, I will call that droplets, due to evaporation, you can create particles that are smaller than 5 microns. So therefore, of interest, I would say, are particles that are 50 microns and smaller, because they could develop airborne particles. They can develop these aerosol particles that can be inhalated, and these are the particles we have to focus. So let's go a little bit back to the past, and let's review some studies about the risk of dental aerosols. Well, the first study that focused on dental aerosols is the study from Mikic and authors, published 1969. So that's around 50 years ago. And well, they say the dental aerobiology is the study of airborne particles in the dental office. And you see on the right side their experimental setup. They place a chamber around the patient's head, and this is an in vivo study. So they place a chamber around the patient's head, and then they filter out the air by breathing, by speaking, by coughing, but also when you treat them with a turbine. Well, that was a low-speed turbine, and with a 3-in-1 piston. And just by this first studies, well, they measure only the bacterial load, the colony forming units, by the way. But here you saw that 50 years ago, they proved that by coughing, you produce 1,000 particles per minute, or bacteria per minute, just by coughing. And the turbine 2,000, and the 3-in-1 piston 43,000. And here you can make a ranking. I told you that there are different instruments that generate these aerosols, and you can easily make a ranking. What do you think? Well, the worst scenario is a water jet handpiece, and that's not on that slide because these instruments are not developed in these days. So the worst scenario is a water jet handpiece, and then a 3-in-1 piston if you use it parallel together, so air plus water, and that's these 43,000. And then a turbine, and this on the Mikic study is not a fast spinning turbine. Today, the turbines are 400,000 rounds per minute, and they will create much more aerosols, much more particle, and much more bacterial loads. And by the way, you saw already a solution there. If you use a high volume evaporation intraorally, you can reduce this aerosol load, this bacterial load, by an enormous factor. And well, therefore, I will focus later on this intraoral high volume evacuation systems. So let's go to the next study, which I really like. It's from 2000 because, well, it's a very clear study, and Bennett checked the risk being infected by tuberculosis. So you treat a patient that suffer on tuberculosis, today SARS-CoV-2, but it's the same situation, and there is the same question. Yeah, is it a risk being infected by this dental aerosol? Well, that was a bacterial test, but it was an in vivo study, and he just checked the bacterial load in different distances. 1 meter, 2 meter, 2 meters are 6 feet, so 3 feet, 6 feet, and they placed these Petri dishes. And what you see in the next slide is one day in a clinic in London in one room. And you see on the x-axis the time. They start at 8 o'clock in the morning. They make a lunch break at 1 o'clock p.m. And on the y-axis, you see the colony forming unit per cubic meter of air. So just follow the red line. It starts at 800. Well, this is the, let's say, the natural load of air. Yeah, so 800 colony forming units per cubic meter. And then they treat the first patient in the morning, the second patient, and nothing happened. But then suddenly, when they treat the third patient, then you can detect these peaks. And these peaks mean that suddenly the bacterial load rises to a factor of 8. And it's like a mountain, it's like a peak. And it's not a steep peak. The time you need to come back to the base level is 30 minutes. And this is exactly that 30 minutes that is recommended in many, many countries to close the room so that the airborne particles, the aerosols, can settle down. So that's the time you have to wait until you treat the next risk patient. So that's, for example, in the guideline in Germany, in the guideline in the UK, well, 30 minutes. And that's quite clear from this study from Bennett. Well, he proves that with bacteria, but I think it's the same aerosol and it will be the same result. So, and then they treat the next patient for no aerosols, another peak, 5 patient, the 5th patient, and then the 6th patient, the next peak. Well, what is the blue line there? The blue line there is just the genus Streptococcus. Well, we know that the biome in the mouth contains 50% Streptococcus. And therefore, if the line follows in a ratio of 50% to the red line, this is a proof that the bacteria that they tested, that they found in 2 meter distance, are coming from a patient's mouth and not through an open window, etc., etc. I think that's quite a clear figure that shows us, okay, it is a risk. There is a contaminated aerosol that that infects that Petri dishes, but not each patient and not each treatment. So the next question of Mr. Bennett and his co-authors was, is this a risk? So that's the risk assessment, the risk evaluation. So if you treat a patient that suffers on tuberculosis, his concentration in saliva of Mycobacterium tuberculosis would be around 70,000 CFUs per milliliters. And then they found out that you inhalate during a 15 minutes treatment this amount of saliva from your patients if you are not protected. So these figures are figures if you're not protected by a mask. So you can inhalate 0.1 microliters, and that's an easy mathematical calculation that would result in an intake of 1 to 8 CFUs per treatment. And from a microbial point of view, this would be enough to be infected by tuberculosis. So, and then Bennett, they checked different treatments and they calculate the risks generating these kind of aerosols. And here you see the different treatments. In total, it's 10%. Well, that's good news. That means in 90% of all treatments, there are no aerosol produced. Drilling 10%, but 50% from scaling by ultrasound, and extraction another 15%, so around that. So interesting thing is, okay, they prove the main risk is ultrasound, but they don't treat with turbines and they don't use free or checked 3-in-1 pistons, so it's not clear yet. But another interesting result is 50% of all ultrasound treatments are without aerosols. And that's the thing I think is quite of interest, because there are mitigation strategies. And I think one of these mitigation strategies is intraoral evaporation. So let's summarize that. Well, it needs 30 minutes to settle down this dental aerosol, and that would be a practical consequence. So if you treat a risk patient, wait 30 minutes, close the room for 30 minutes. Well, you contaminate everything within 6 feet, so therefore you have to disinfect, especially these areas, and you contaminate everything, door handles, armrest, etc., etc., etc. So let's do now a risk assessment. Do we play Russian roulette? Well, it was proven that it's possible being infected by tuberculosis, and it was proven that it is a risk being infected with hepatitis C. Well, and in the 70s, the main risk was hepatitis B, by the way, but there's a vaccination available, so it's no risk today. But it was proven, and due to the really high number of SARS-CoV-2 in saliva, I found figures of around up to 7 million virions per milliliter saliva. I think it seems quite probable. And if you just do the same calculation as Bennett did, if you just calculate this inhalation of 0.1 microliters of saliva and divide that by these 7 million per milliliters SARS-CoV-2 copies, that would result in around 100 to 1,000 coronaviruses per treatment. And well, it is estimated that this is enough, but the evidence is not clear. So I think the risk of this dental aerosols is much smaller than other medical aerosols. And therefore, just from the point of a risk assessment, you cannot sort that out, either positive and negative. So therefore, we need mitigation strategies. So what are the right mitigation strategies? If you just divide your operation area into these 3 zones, zone 1 is the mouth, zone 2 is, let's say, 1 meter. That's the operation area, direct contacts, etc. And then zone 3 is 6 feet and larger. What are the mitigation strategies? If you just check the CDC's website, the first mitigation strategy is prioritization. Prioritization, that's, well, a good statement, but hard to transfer that into real life. Prioritization would mean, well, in Germany, if you go to a dental clinic, you have to fill out a questionnaire. Do you suffer on fever, cough, sneezing? Did you have contact over the last 10 years? Well, in Asia, they measure fever. Well, in Australia, you have to perform an antigen test before you enter a clinic. This is prioritization. Yeah, it's your, but sometimes you can't say, okay, I will not treat that, this patient. Prioritization also in terms of, do you use AGPs, yes or no? Well, my statement is you can't avoid that. So I think this is a kind of politic discussion now, and I don't want to open that box. I also don't want to speak about mouth rinsing solutions, because in February, March, everybody said CHX is not active. We have to use H2O2, chlorine solution, etc. But there are much more new studies that prove that, well, sometimes CHX is helpful, or PVP iodine or whatever. So I'm not a drug advisor. You have to check these studies by yourself. What is proven is the effect of intraoral evacuation, so-called HVEs. That's proven. And well, as a mitigation strategy, of course, you have to reprocess your devices, your instruments. So in zone 2, that's your daily work. You wear personal protective equipment, you disinfect everything, and this is maybe the main reason why in dentistry the numbers are not as high as in other medical areas, because we normally use gloves and goggles and etc., etc. So that's our standard procedure to protect ourselves. Well, and then we can discuss some methods in zone 3. You know, there are a lot of air filtering systems in discussion, purification systems, UVC light, and other disinfection methods. Well, those methods you need if you can't remove or mitigate zone 1 and zone 2. And we have to discuss if this is necessary, yes or no. So, ladies and gentlemen, let's focus on one mitigation strategy. And that's the mitigation you use in your daily work. And this is the intraoral evacuation. And before we go into detail, and I want to show you another study, I want to have a look back. This intraoral suction system, the intraoral evaporation, are developed in the 50s. Here you see some mobile systems, but the vacuum and the volume was very low, and those systems are used as just as a saliva extractor. So therefore we call these kind of systems low volume evacuation systems. And then in the 60s, new systems are rising up, and that's what we called spray mist suction. They use a much higher volume, and therefore you call them HVEs. HVEs as a contrast to the low volume evacuation, the saliva extractor. But the question is, what are efficient HVEs and what is the critical parameter? And here I found one of the first studies from the 70s, made by Davis and co-authors. You see the setup on the right side. It was an in vitro study. So they use in vitro tooth, they use a turbine, and then they use HVE. But this time they manipulate vacuum and they manipulate flow rate. And here you see a quote of the results. The use of a flow rate of 300 liters per minute, which is around 10 SCFM, fulfills both requirements. And one requirement is to remove the aerosol. And the second requirement, and that's what's also quite important, they do not, these flow rates did not remove the cooling water. So they cannot measure any temperature increase on the pulp. So that was their setup. So they use temperature sensors in the pulp, and they measure the heat that will be generated by these turbines. So 300 liter is the optimum, 10 SCFM. And another statement is that negative pressure up to 200 mercury are safe? Because people are asking, well, if you touch the gingiva, is this safe? Yes, negative pressure up to 200 mercury are safe. So the question is, this is, I think, quite a clear image. You treat with a high-speed turbine and you use only a saliva extractor. And I think it's quite clear on that picture that you can easily visualize that aerosol. But there are very, very less studies published that really quantify the amount of aerosol, dental aerosol you produce, and that quantify the, let's say, the size, the speed of these aerosols, and therefore it's hard to do a risk assessment. How many aerosol is produced? Is it, don't know. Yeah. The mass per minute, that would be an interesting question. And therefore, I just go a little bit through the history. There are a lot of studies published where they used a dye. They add a dye into the water, and with this test set up, they contaminate the areas. And then they just make photos, and then they quantify the contaminated areas. But these studies, they prove the contamination, yes, but they do not prove, is this by droplets, by splatter, or by fine aerosol particles? From these studies, you cannot estimate the risk if you inhalate something. So therefore, we try to find out new methods. And that's a picture I already showed. This is a wonderful new method. It's not published yet. It's a method which is called 3D particle image velocimetry. With this method, you can really live see each particle. Well, you need a high PC power, you need a strong software, and you need modern imaging techniques to perform that. And another nice imaging technique is made by NSK or other companies, and they use lasers, and this technique is called particle image velocimetry to visualize this aerosol produced on the right side with a standard air turbine, and on the right side with a manipulated low aerosol producing handpiece. So I just don't want to go to the different brands. I just want to show you that there are new techniques to visualize and to quantify these dental aerosols. Now, our question was during summer, how efficient is intraoral evaporation? How efficient is an intraoral evaporation? And during the next slides, I want to publish, and it's not published yet, I want to show you the first results of that study. I used a so-called shadow imaging. You see that on the picture. A shadow imaging is a technique that is used in industry to measure sprays. So high speed, small particles, sprays. Well, in industry. And here you see the setup. So on the left side, there is a backlight that consists of very fast flickering LED lights. And on the right side, you see, well, a high-speed camera. Well, there are two cameras inside, but this is a side effect. So, and what these two optical systems create is a so-called optical frame. And this optical frame is, you saw that in the picture, is 6.5 times 5 times 1 millimeter. And we place that exactly 5 centimeters, so 50 millimeters in distance to the upper right front teeth. And the big advantage is it's, well, this technique, it's just an optical technique. You do not influence the flow. And that's the big advantage. So, and what we compare are different intraoral suction solutions. You see on the left side, I call it a non-optimal suction position. The picture, the second picture is a better suction position, and then we check quite different cannulas, HVEs, different styles, different adapters, different suction systems, and we measure the amount of particles that emit the mouth. And this is just one result of one measurement. This is the result of the framist of a turbine. Well, this system again is a live calculation. It calculates live 127 images within 1 minute or something like that. And it quantifies the size of each particle and the velocity of each particle. And the results you can see on the right side. A spray mist of a turbine generates particle between, let's say, 80 microns and smaller than 5 microns. And you see that the highest amount of particles are on the left side, and this is our resolution limit. And that's some disadvantage of this method. The resolution limit is 5 microns. So the left column is 5 microns. So the take-home message is you generate a lot of particles per second in the range of, that's our focus, 5 to 50 microns. Well, and the second result on the right side is the velocity. Because if you know the velocity, then you can calculate the energy you need to slow down the particles and to evaporate these particles. So therefore, that's a quite interesting result. So what did we test? We test different suction HVACs. You see that on the right side. We start with a very huge diameter, 16 millimeters, and then with a different design, a third design, and then we compare it with a saliva extractor. And the result is that on the left side, 100% aerosol reduction. That means 700 particles per second without a suction. If you switch on the suction, 0. We do not emit any particle in 5 centimeters distance with a 16 millimeter HVE. 1, 2, 3. But with a saliva extractor, only 38% aerosol reduction. And the reason is on the first line. That's the flow rate. The flow rate is larger than 10 SCFM for the first one. And due to the small diameter of the saliva extractor and the adapter and the tube, you reduce the flow rate to 2.5. And the result is an aerosol reduction of only 38%. So you emit more than 400 particles per second. Yeah? And well, that's a big problem. Well, and then we compare other suction solutions. For example, smaller HVEs with a smaller diameters or a smaller hose or suction systems with a high vacuum but a low flow. And here you see the results. And we test several different things and everything comes to one result. And that's summarized in this figure. Let's go a little bit into details. Let's go to the zero suction. That's on the left side here. Without a suction, you emit 700 particles per second, so 0 reduction rate. If you increase your flow rate to 10 SCFM, which is on the right side of this curve, of this S-curve, you remove 100%, no particles that are emitted if you do a suction technique you see on the picture, a non-optimal suction technique. And then there is, I call this is a tipping area, a tipping factor. That's around between 6 and 7 SCFM. Yeah. If your intraoral evaporation is smaller than 7 SCFM, there is no effect measured in this in vitro study. So that's the clear consequence. And this is independent of the vacuum. This is independent of the design of the cannula. There's one key factor, and that's flow rate. Flow rate is the key factor. Flow rate is the physical key factor that slow down the particles and that remove the particles out of the mouth. Flow rate is the key. And I just want to quote Steve Harrell. He's now in Texas, and he published together with Mr. Molinari a wonderful cover story in 2004. And just to quote him, the use of high volume evacuator can reduce the contamination by more than 90%. So we prove 100% with our in vitro study, but, and that's the most important statement, a high vacuum does not remove a large volume of air. And this is not considered as a HVE. Vacuum is not the important factor. It is volume. And just to explain that in easy words, a muscle car is not the best way to transport something from A to B if everything is blocked. You need a free flow. You need a high flow rate to transport something. Vacuum is not the right parameter. Flow rate is the key. So, and let's finalize that. How can you improve your flow rate of your intraoral evaporation? Well, the first method, and I will show you 5. The first method is you can optimize your suction technique. And that's another result of our study. If you optimize your suction technique, you can, to a special extent, increase the aerosol reduction, but only if you are in the green, in the yellow zone. I divide that results into 3 zones. The green zone is the gold standard. It's a flow rate of more than 10 SCFM. And then you have got the orange, and that's between, or the yellow zone, that's between 7 and 10. And here you can optimize that, and then you will see an effect. 60% aerosol reduction, 70% aerosol reduction. But if you're in the red zone, well, that's a problem. Let's check what you can perform. You can optimize your suction technique, and that's really something that is also recommended by the CDC. Work in pairs using four-handed methods. If you work alone, then optimize your ergonomic suction technique, and that's what you see in that slide. You need the right tools. You need ergonomic tools to optimize your technique. This intraoral evaporation, it's the gold standard in mitigation. Well, second tip, use cannula and adapters with the large diameters. Small diameters will ruin your flow rate because of the high resistance. You need large diameters. And by the way, if we are talking about cannulas and HVEs, please keep in mind there is a so-called backwash published. So if you stop the flow, then it could be, I call it liquid. That liquid can flow back to your patient's mouth. And that's normally not the liquid from the patient, by the way. It's the liquid from the morning. So, and that's, therefore I call it liquid. And there is a solution available from different manufacturers, and this solution is called secondary air inlets. So new cannulas, new HVEs contain this secondary air inlet, and they open automatically when you block the flow. So this is just one recommendation. And the second recommendation is take care of your suction, take care of your adapters. And this is published by Coleman in 2010. Normally, you just reprocess your HVE, but not these adapters. And just disassemble that and just check it. So check the manuals of the manufacturer, how you have to disassemble that and do a right reprocessing. Because, well, if you evaporate the SARS virus and therefore contaminate the next patient, nothing helps. So tip number 3, remove the resistance in your suction pipings. Clean your suction system daily. Yeah, if you reduce the diameters, if you block your suction line, you ruin your flow rate. So this is just my 3rd tip, and therefore there are a lot of products on the market to clean your suction system without destroying membranes and valves, etc. So use the right product to clean these suction systems. And tip number 4, well, the first 3 are easygoing. Yeah? These are tips and tricks you can do daily. Well, this is a little bit harder. But if you invest in, then please invest in new pipings. This is a piping plan that is optimized. Each elbow ruins flow rate. You need optimized piping with a large diameter of 40 millimeters, for example. So ask your dealer to do a right piping. Well, and the 5th is check your hardware. Because many clinics, they owned, well, quite nice suction systems, but most of them, they are focused on vacuum and not on flow rate. If you go through an exhibition, yeah, many dentists just check a suction system with the thumb. They press the thumb against the HVE to prove the vacuum. Well, if you understand that flow rate is the key factor, sorry, that's not the right way to test a suction system. And this is the right way to test the suction system with a flow meter. And this is my last chart there. Here you can see a comparison of different suction systems available on the market. I just delete all the manufacturers. What you see are 4 different lines. Let's start on the left side. When you use only one HVE in the first operatory, most of them can create nice flow rates. You see there up to 10, 12, up to 14, 13 SCFM. But then you open the second HVE in the second room, in the third, in the fourth, and in the 5th room, and there you see the difference. The red zone is 7 SCFM. So everything that's in the red zone, yeah, will not remove any aerosol in this in vitro study I published. So, and that's a big consequence. So many suction systems are optimized to vacuum and not to flow rate. So it's an easy tip. Just check your flow rate and they can easily measure that and prove how efficient is your suction system. So, ladies and gentlemen, let me come to an end. And let me ask or answer the question that I raised up in the beginning. Dental aerosol, is it a significant threat? And I don't want to answer that. I want to quote 3 statements. The first statement is from the CDC. If aerosol generating procedures are necessary for dental care, and I think they are necessary, use four-handed dentistry, use high evacuation suction, and that's what they recommend, use rubber dam, because with rubber dam you can separate saliva and blood from this liquid. A second statement from the Cochrane Library. Another interesting statement, and that's from November. We found no studies that evaluated disease transmission via aerosols in a dental setting and no evidence about viral contamination in dental aerosols. That's exactly also my statement. There is no evidence. A range of approaches can be used to reduce the potential infection via these aerosols because, well, SARS will go away, but the next disease will come. So therefore, we have to focus on our of these dental aerosols. And these include local ventilation using a suction device, a high volume evacuator. That's exactly their statement. And my last statement is the guideline from the German Dental Association. And they say use a high volume evacuation and cannula wider than 10 millimeter. If this is guaranteed, there is no reliable evidence with regards to use any additional suction devices you see there. I think there is no need for any additional extraoral suction systems. If they're handmade or not, I think you've got a wonderful solution in your daily hand, and this is the intraoral evacuation. So my summary of today's webinar is dental aerosols are less infectivity that everybody thought. You use normally routinely your PPE and disinfections, and this helps you to be protected. There are a lot of successful mitigation strategies available that help. And the gold standard is an intraoral evacuation at source. At source. And that's the principle of non-contamination. You remove the aerosols at source, but therefore you need flow rate. Flow rate is the key, and it's not vacuum. Flow rate lower than 7 SCFM is too low. It has to be more than 7 SCFM, and the best results are more than 10 SCFM. And if you are interested in that pilot study I did that proved the effect of intraoral evacuation, so please follow that link, www.airdechtechnics.com, EN and aerosol protection, or Google this. Here you can download this pilot study published by me. Well, and hopefully in January, it will be published in an international journal. So up to that, it's just a white paper. So ladies and gentlemen, thank you very much. And we are open for discussions. Please use the F&A tool to write any questions inside. And let me check if there are any questions. And I think I have to stop my presentation here. Yeah, thank you very much. And let's check your questions. Is there a way, the first question, is there a way to measure flow rate without a meter? For example, timing how fast a set amount of solution is evacuated per minute, or is that simply measuring vacuum rate? You answer that directly. If you remove water, then you measure vacuum. Yeah, you have to measure air per minute. So SCFM, air per minute, and therefore you need a flow rate. Sorry, you have to measure that with a flow meter. Are funnel-like attachment to the AVA system safe to use, about 3-inch diameter for aerosols? Okay, is it possible to use, let's ask a different question. Is it possible to use intraoral HVE system as an extraoral system? Yes and no. You can try it. It depends on the aerosol. As I told you, the particle emits with a specific velocity, and you need a counter velocity to slow them down. And the velocity depends on the distance. So therefore, an intraoral evaporation is the gold standard, especially when you use an optimized suction technique. You need small distance. Yeah, if you use extraoral systems, those systems are working with 100 SCFM and higher because they have to work in distance. So the answer would be yes, maybe there is an effect, but the effect is very slow. So let me check more questions. There is a question concerning masks. Should we continue to use N95 masks after this pandemic is over? Are level 3 surgical masks sufficient? Oh, this is a interesting question. Well, we can discuss hours about studies on masks. You know, the filtering efficiency is lower for N95 mask and the level 3 masks. But it depends on the fit. Yeah, for my opinion, a level 3 mask fits much better than an N95 mask. So if you optimize the, how should I say, the fit, yeah, then in theory N95 is better. But in most cases, a level 3 surgical mask is better due to the fit. And I just can tell you the recommendation in Germany. You have to use an N95 mask if you treat a risk patient. And if you do a risk evaluation and the risk evaluation says, okay, low risk, then you use a standard surgical mask. That's what they do during this pandemic, before and after. The dental high-speed drill produce more or less aerosols than the dental hygiene magnetoscaler, piezo hygiene scalers. I just can tell you the result of my study. It's a different aerosol to answer like that. A high-speed drill, yes, it produces more aerosols, bigger particles, larger size with a higher speed. The aerosol of this ultrasound devices are a little bit smaller and with a lower velocity. And if you understand my webinar, then you know the consequence. An aerosol created by an ultrasound device is much easier, can be evaporated much easier than an aerosol generated by a turbine. Or the worst scenario is an aerosol generated by a powder water jet handpiece. Next question, how much area cover aerosols? Well, the common sense is that they contaminate approximately 6 meters. But to speak in clear words, this depends on the flow. You know, when you open the window, then the flow goes through the window and then it's not a circle of 6 feet. Yeah, so I would say this is without any air condition, without a flow, but in these days, yeah, you should open the window to create a flow and the dilution of the air. Can you use two HVEs devices at the same time? For example, ISOVAC with a hand AV tube. Should we test the flow rate of using both at the same time? I think the question goes in that direction. Is it possible to use two HVEs in one room, parallel? Well, once again, this depends. It's hard to say because it depends on the pipings and depends on the hoses. You just have to measure it because if you just do this measurement, you use the HVE and you use this saliva extractor. If you switch on both, then you reduce automatically the flow rate of the HVE. Yeah? So yeah, you have to measure it. We cannot say that. Would you consider isolate system to be the same or better than HVE systems? I cannot answer that. We did not measure the isolate system, but I think it would be the same. The key factor is the flow rate. And well, that's something we have to do, yeah, or we should do. We should measure the flow rate of the isolate, and then maybe we can give an answer to that. So we do not test isolate. So more questions? Yeah, another question, quite interested. Any benefit of negative pressure room to mitigate office risk outside of operatory? Oh, that's a question that rise up during summer, especially in South Africa. I did not find any study that prove that there is a benefit, but today we discuss a question from attendees last time, and he raised up the questions. Didn't we generate a vacuum in our operation, in our room when we use intraoral evaporation? And I thought, okay, that's right. We create a vacuum because we use 310 SCFM and we transport the air outside. So it is a small vacuum. I do not know if this is a vacuum that can prevent these aerosols going out of the room. But well, as I told you, if you use the right flow rate, there are no aerosols. We couldn't measure any aerosols. And there are other studies in, for example, at universities, also in Germany, where they treat patients, where they 10 students treat patients in one room. If they use a high volume suction system, the main cause of aerosols are the students inside the room and not the dental treatment. But these studies are not yet published. So, and a running gag is the highest risk in dentistry, if you wear personal protective equipment, are the breaks, the coffee breaks in the break room, because there all your personnel talks to each other, sits there, drinks coffee without masks, and that's the highest risk in dentistry. But this is a running gag. But that's my estimation. Okay, more questions? There is a question, where would we get a flow meter? Well, this webinar is sponsored by Airtechnik. I think they will send you an email with a possibility to check the flow rate. So that's possible by your dealer or by the employees of Airtechnik. Okay, more questions? No, we are 5 minutes over time. Maybe you saw my email address at the end of the slide. It's martin.koch@dürrdental.com. So don't hesitate to write emails to ask me, and please perform the test to gain your CE credits. And there's also a questionnaire. How do you like this webinar? So give me a plus, and thank you for attending this webinar. Goodbye. Goodbye from Germany, and keep safe during these difficult times. Goodbye.
Thanks for attending this Viva Learning webinar. In order to get your CE credit, you will need to pass the CE exam. To do so, return to the website, make sure you are logged in, click on either CE in Progress or My Account. Click on the webinar title and take the CE exam. Thank you, and see you next time on Viva Learning.